We're going to discuss intestinal permeability, systemic disease, the pathogenesis of the disease, and the various tests and new therapeutic strategies which we now have available to us. The diseases that are associated with zonulin are actually quite large. In terms of autoimmune disease, you've got the inflammatory bowel diseases such as Crohn's, ulcerative colitis. There's celiac disease, diabetes, type 1 variety, a whole number of others, including rheumatoid arthritis, etc. In the area of the nervous system, multiple sclerosis is now probably there is a feeling that it is autoimmune. Of course, whether the polyneuropathies are and schizophrenia is not as well understood. And when you look at the cancers, there are a number of cancers that now seem to be having some relation to the permeability of the gut. We do know that the gut or intestine and autoimmunity, 1 in 6 Americans have autoimmune disease. And about 1 in 14 have autoimmune thyroid disease. So it is not an insignificant issue. The pathogenesis of autoimmunity can be understood if you look first at the conventional theory. And in that theory, it basically states that you need to have a genetic component. There needs to be some kind of a pre-existing intestinal anomaly in the cells, whether it's in the genetic makeup of various parts of the intestinal anomaly. In celiacs, for example, there's a very, very high response of the HLA DQ2 and DQ8. Added to that, you need to have some kind of a trigger. There needs to be an environmental trigger, an exposure to either intraluminal antigens and or bacteria. If you have both of these, the conventional theory says those pathogenic factors would need to be common to the creation of some kind of an autoimmune response or disease. The new theory of the pathogenesis of autoimmune disease says that, yes, there is a genetic predisposition. There also are environmental triggers, and that will cause autoimmune disease. But there is now a third factor. There is in this triad a disrupted intestinal barrier. And that disruption and its reestablishment is what can modulate or reverse an autoimmune process. So this is quite a remarkable new idea in a theory, that you can actually modulate or reverse. So if you were to look at this and take a look at that intestinal barrier function, that third part of the triad, we now understand that there is an important role that is played by zonulin, by this biomarker, in modulating or reversing the effect on autoimmune disease. So let's take a look at 4 of the classic groups in order to get some idea of how this would work. Let's first look at celiac disease. Gluten structure and understanding of celiac disease, you do need to know that the proteins gliadin and glutenin are basically the 2 proteins which are critical to understanding the effect of gluten. These are 2 proteins which are toxic for celiac patients. And here is a micrograph showing you both the glutenin and gliadin. This is from Fasano's study in 2011. Gluten has within it the alpha-gliadin peptides, and here is a very elegant study. This is from Fasano, but comes from a whole series of different studies in which they were able to show that peptides within this alpha-gliadin chain can have either toxic effects, portions of it can liberate the CXCR3 receptors being held by interleukin-8, especially in celiac patients, and the part that you see in dark blue is the portion, the peptides, which can liberate zonulin and therefore change intestinal permeability. So from the diagram that we saw in part 1, where you're actually looking at the antigens that are coming into the lumen and what kind of effect they can have on autoimmune response, If you look at celiac disease, let's take a look at what we call our triad, the genetic predisposition. For example, in celiacs, the very, very large reaction of HLA and molecules together with the environmental trigger, which of course in the case of celiac disease is gluten, and added to that this leaky intestinal barrier, the opening of the tight junctions that allow the antigens, the macromolecules, the portions of the alpha-gliadin to get into the system and cause the problems we see in celiac disease. So the leakage effect of gliadin and zonulin are known to be much longer and greater, in fact 5 times or more in the enterocytes, the cells of the gut, in celiacs. In fact, celiacs produce about 30 times more zonulin than non-celiacs, and therefore have 3 times or even greater intestinal permeability because of this zonulin effect. And because of that, gliadin activates zonulin signaling, which then leads to an increased intestinal permeability to macromolecules. Those macromolecules would normally not be able to penetrate the tight junctions. And so if you look at then the causes of increased zonulin, and therefore the development of a leaky gut, what are they? Well, there are 2 major groups, of course, gliadin in the diet, and the overgrowth of harmful organisms, such as bacteria that are in the small intestine, various kinds of fungal dysbiosis or candida overgrowth, and the realm of parasitic infections. Now, patients suffering from celiac disease, if you remove the gluten from the diet, what happens is that serum zonulin levels decrease. And because they're decreasing, the intestine is able to resume its baseline barrier function. It's that dynamic effect that zonulin has. And because of that, once you remove it from the diet, the autoantibody titers are normalized. Otherwise stated, the autoimmune process shuts off. And therefore, the intestinal damage, which of course is a biological outgrowth or outcome of the autoimmune process, is able to heal completely. If you look at zonulin in the small intestine, here's some immunohistochemistry. You take a look and you see that there are just a few zonulins in a control subject, whereas in celiac disease, unlike the control, you are looking at multiple zonulins which are actually going onto the receptor sites of the enterocytes. So celiac disease has a tremendous amount greater zonulin. Let's look at inflammatory bowel disease. In inflammatory bowel disease, there's increased intestinal permeability, and that is central to the pathogenesis of the disease. It's due to innate immune deficiency, which then leads to inappropriate access of antigens coming from outside to the body, which then stimulates the associated lymphoid tissue response. And what you do know is that in asymptomatic Crohn's patients with no symptoms, increased intestinal permeability precedes a relapse by up to 1 year. So it's extremely important to understand the effect of zonulin. This increased permeability defect, therefore, is an early event in the exacerbation of the disease, which then is perpetuated by other cytokines, by other types of triggering mechanisms. And it is important then to note that in the pathogenesis of IBD, of inflammatory bowel disease, there's a defect in the intestinal barrier caused probably by zonulin pathway activation. Nevertheless, both of these together, whether it's zonulin and other factors, of which zonulin is very important, they do create an increase in intestinal permeability. That in turn gives you the increased inflammation, which then leads to a tremendous production of cytokines, interferons, necrosing factor, the interleukins, etc. This then leads to a reorganization of the tight junction proteins, otherwise said, an opening of the tight junctions, and that in turn is able to lead to even more permeability, which then leads into a feedback loop and the effects that you get with intestinal problems. When we take a look at serum zonulin and its effect on different types of multiple sclerosis, which up until now has not been as much in focus, we begin to understand that relative to controls, those with relapsing, remitting multiple sclerosis or secondary progressive MS have, about 30% of the patients have elevated amounts of zonulin. And in fact, those patients have a twofold increase in the amount of zonulin relative to the controls. And when they go into remission, their levels decrease close to what it is with controls. Diabetes, if you look at the effect of intestinal permeability on type 1 diabetes, what you notice very interestingly, and it's quite dramatic, is that those with T1D, type 1 diabetes, and even their relatives have a very, very significantly greater amount of serum zonulin, and their lactulose mannitol sugar test is also significantly greater than it is in controls. In fact, in a study by Sapone, he showed that large subgroups of those with type 1 diabetes experience zonulin-dependent increase in their intestinal permeability, and they do that prior to the disease onset. So it's the loss of this intestinal barrier function, which is secondary to zonulin upregulation, which is able to switch what would normally be tolerance to an immunity response to some of these non-self antigens, leading to what we now know as diabetes. So the autoimmune response should therefore be able to be stopped and perhaps reversed if we can work on this interplay of the autoimmune predisposing genes and the triggers, hopefully to prevent or eliminate diabetes. So the important message here is, for autoimmune disease like type 1 diabetes, reestablishing the intestinal barrier function represents a valid, innovative, and an alternative therapeutic strategy. Really quite an interesting thought. Some of the other diseases that we can look at very briefly, one of them is dermatitis herpetiformis. Now, that is a skin expression of celiac disease. One would like to be able to differentiate that from a dermatosis, a linear IgA dermatosis, which is very similar to DH, but the IgA deposits on the dermal epidermal junction. And so by looking at permeability testing, there may be a very simple, non-invasive way to differentiate dermatitis herpetiformis from a dermatosis. In the case of obesity, very intriguing in seeing that serum zonulin levels are significantly higher in the obese than they are those with normal weight. And in fact, it is now being said by a number of people in the field that it could be a potential marker, zonulin that is, of systemic microinflammation, which is associated with obesity. So higher circulating zonulin can modulate the intercellular tight junctions in obese subjects. And of course, zonulin is proportional, in this case, to the total bacterial count. In the case of obesity, the high growth of gut microbiota, you're really looking at a high energy consumption by the obese with a high dietary fat component. And so the increased intestinal permeability that is seen in the obese may be the effect of long-lasting, inappropriate nutritional habits, which then have an effect on zonulin and permeability. So we therefore get back to this idea of the new theory of pathogenesis, that you have a triad for autoimmune disease, the genetic predisposition, the environmental trigger, and of course, this intestinal barrier function. So the clinical use then of intestinal permeability is, in terms of screening tests, would be to identify and measure intestinal permeability to macromolecules that would then be able to cause the immune system to become hyperactive. You want to identify the route that's taken through this intestinal barrier, and therefore, as Isabella Wetz said in 2013, testing for and eliminating intestinal permeability should be the first issue that is addressed in all cases of autoimmunity. So for patients with the following: headaches, migraines, poor memory, low energy, anxiety or depression, of course the realm of acid reflux, abdominal bloating, chronic gas or constipation, and of course both food intolerance and allergy, one wants to be able to look at all of these symptoms in being able to diagnose autoimmune disease or abnormal immune cell counts. So what kind of tests would you want to do? The primary screening test should really be looking for damage to the tight junctions. And if you want to look at that, you do need to do a serum zonulin test, which has a very, very quick way of being able to tell you the damage that's being done to the tight junctions. There are a series of secondary tests. The damage to the permeability or dysbiosis, if you want to look at that, you would be able to do that by testing for bacterial lipopolysaccharides. They're in the blood, IgG, A, and M. They normally should not be found in blood. They should only be found in the intestine. And so if they are found in blood, then you know that there is some damage to permeability and dysbiosis. If you want to know about damage to the epithelial cells, one of the things is to look for the blood IgA of actinomycin, because that's one of the proteins that is part of the group in the tight junction of the enterocytes. Checking for generalized leakiness, there is a well-known 6-hour urine test, which is the lactulose mannitol test. These are non-metabolized sugars, which normally are not detected in a urine sample. If they are, then it can give you an idea of small intestinal bacterial overgrowth. It should be noted that it is non-specific as a test and is really a very poor correlation with macromolecule permeability. Some of the other secondary tests, if you want to test for the allergic inflammatory response and an ability to decrease inflammation, one of the tests to do is for histamine, to show if there is an inflammatory response, and the well-known diamine oxidase test, DAO, to find out if histamine is in fact being broken down, which is what DAO does. If DAO is low and or histamine is high, one should be looking at various kinds of diets and supplements to be able to see how that allergic inflammatory response changes. And of course, the risk of developing an inflammatory disease is really one that should be done with real-time PCR. You really look for the haptoglobin alleles by looking to see what kind of the genetic polymorphisms there are and how that correlates with the risk of developing immune-mediated disease. So finally, in terms of new therapeutic strategies, one really is looking now to the reestablishment of intestinal barrier function. And one of those things which was mentioned earlier is the possibility that a zonulin inhibitor, which is now in clinical trials, larazotide acetate to be particular, does have that possible capability of being able to stop zonulin's effect. By doing that, you therefore would prevent the loss of intestinal barrier function or prevent the appearance of autoantibodies and therefore the onset of the disease. So pre-treatment with something like larazotide or other medications like that that are going to come out may be able to protect us against diseases such as inflammatory bowel disease, celiac disease, and diabetes. Quite a statement to make. And I think we are on the cusp of this kind of treatment becoming part of the armamentarium of the medical community. The zonulin pathway may also be able to facilitate the delivery of therapeutic agents and antigens through several epithelial and endothelial barriers. In other words, if we know that tight junctions can be opened, why don't we use it to good effect to be able to treat problems of the GI tract, of airways, and even of the blood-brain barrier. And so we have discussed zonulin and intestinal permeability, and I leave you with a picture of the windows in my home during the summer in Montreal. No, it's not that cold. We have some beautiful weather, and I want to thank you very, very much for your attention.